guys, I'm assuming you haven't been over local anesthetic yet in pharmacology course. Okay, so just going to do this pretty quickly as well. Local anesthetic pharmacology, chapter 20, Gilman reference. Okay, local anesthetics work at the level of nerve cell membranes. Okay, and you guys know local anesthetics, like you go to the dentist and inject a local anesthetic, or if you're getting sometimes some kind of little work done on skin or something, you get a local anesthetic injected there. So that's what we're talking about. Wow, what local anesthetics do is they stop action potential generation and conductance, and they do this by decreasing cation permeability in these neurons. Okay, and the effect is pretty specific, and so fairly simple. The reason I say this stuff is pretty simple is because the effect is going to be at voltage-gated sodium channels. You guys remember voltage-gated sodium channels? Right, they're the channels that are all involved in action potential generation. Right, so when a nerve is having an action potential, right, that it'll depolarize to a certain point and reach threshold, and when the nerve reaches threshold, that's when those voltage-gated sodium channels open up, and then the nerve then has that action potential as sodium rushes in and causes membrane changes, depolarization of the membrane. So what these guys do is they block the actions of those voltage-gated sodium channels, and the binding sites of them are actually, they don't go and bind the channel from externally. What they do, as we'll see, is these local anesthetics cross the membrane, get into the cell, and then they come back and block these channels. So local anesthetics need to cross the membrane to be effective, and then once inside the cell, they ionize and they enter sodium channels, and then they block the sodium channel. Okay, so real simple slide here. So voltage-gated ion channel activity. So over here is the resting potential. When voltage-gated ion channels are closed, and then when there's, as you remember, when an action potential occurs, these voltage-gated, or when threshold is reached for an action potential to occur, these voltage-gated sodium channels open up, sodium rushes in, membrane depolarization happens super fast, and you have an action potential. As we'll see with these local anesthetics, what they're going to do is they're going to come into the cell, and then when these sodium channels open back up, they're going to get in here, they're going to ionize within the cell, they're going to get in here, and they're going to block this activity here. Okay, and that's shown in simple form in this slide. So here we have a sodium channel, the local anesthetic again, it's going to be this X, right? I have the X in blue, it's out here, it's not ionized, it crosses into a cell, so things like lidocaine, cocaine, what have you, inside the cell gets ionized. When the sodium channels open back up again, when another action potential occurs, then these things are going to get up there and block those sodium channels. So you're going to block the generation of action potentials. Okay, and these guys must be open for the anesthetic to enter. And what that really means, and this is in subsequent slide here, is that the degree of electrical blockade that you're going to get with a local anesthetic is going to depend a bit on the nerve's resting membrane potential and the stimulation history of the nerve. So the more stimulated a nerve gets in the presence of local anesthetics, the faster actually that nerve is going to be blocked, because more of those sodium channels are going to be open, right? The local anesthetics are going to get into those sodium channels and block their activity. Okay, so what that also means is that a non-stimulated nerve is going to be less sensitive to a local anesthetic as compared to a repeatedly firing nerve. Okay, and then so that's really super simple local anesthetics. That's how they work. Other stuff gets used with local anesthetics to try and increase their effectiveness. And one way you can do that is you can give agents that cause vasoconstriction that will enhance and prolong the effect of local anesthetics. And it also allows for some localization of, extra localization of anesthetic. So you stop the blood flow going to an area. So you among other things, you stop the local anesthetic from being carried away too fast and having activity. Okay, and it's also, it helps allow for the rate of anesthetic metabolism to match the rate of absorption into the circulation. So, what's a vasoconstrictor? Anybody remember? Epinephrine, something like epinephrine, phenylephrine gel. What receptors is that targeting? You got to know the exam. Alpha-1, right? Receptors, vascular smooth muscle. Target alpha-1 receptors. They got alpha-1 adrenergic receptors coupled to GQ, right? When they're activated on vascular smooth muscle, muscle's going to contract. You have vasoconstriction. That's what you definitely need to know for the exam. Okay, so in terms of local anesthetics and their use, typically patients, when you give somebody a local anesthetic, you're going to get a loss of pain sensation, followed by a loss of temperature, touch, and deep pressure sensation. And over time, you give too much of these things or a lot, you can actually get loss of motor control as well. There are potential problems with using local anesthetics. So you can have some tissue damage because co-injected some pathomimetic amines, vasoconstrictors, right, actually increase oxygen consumption, but there's less oxygen being delivered, and so you can get some tissue damage with these guys. Organ function can be compromised with local anesthetics if you're not careful. You know, yeah, you're injecting them locally, but things, you know, if you inject too much, you know, nothing stays locally, right? It's going to get throughout the body. So you don't want to give too much. If you do give too much of a local anesthetic, you can even get things like CNS stimulation, you know, you're doing that sort of thing, and you get tremor, restlessness, etc. And you're messing with voltage-gated sodium channels, which have all kinds of different actions throughout the body. And also, these things can deposit in the muscle, so you can get some systemic toxicity that way. There are cardiovascular issues that can occur with local anesthetics, as this slide says. You get decreased excitability level of the heart, because again, you're blocking the activity of voltage-gated sodium channels, so you're blocking normal actin potential conduction. And if you get too much of these things get to the heart, you can have problems. You get decreased excitability, conduction rate, decreased force of contraction of the myocardium. At smooth muscle, the local anesthetics are also going to decrease contractions, and that can happen in the bowel and intestine as well. They can actually have some relaxing effects on the vascular smooth muscle, again, because these sodium channels are involved in all sorts of different things. Okay, and just clinically, I guess some people are super hypersensitive to local anesthetics, and they can get allergic dermatitis or even an asthma attack. And so one thing is, it's important to distinguish is somebody having an allergic reaction to, say, a small amount of a local anesthetic, or if you give them too much of that, and you're causing the person to have a systemic issue because they've got too much anesthetic. So you want to, if somebody's having a reaction, you want to think your way quickly through which way is that being caused. Okay. In terms of the local anesthetic metabolism, again, you know, if this stuff gets throughout the system, throughout the body, and not staying locally, you can have problems. So the toxicity is going to depend on the balance of the rate of absorption and elimination. And metabolism of local anesthetics can vary a lot depending on what tissue they're being given to, and whether they're being co-injected with vasoconstrictors, etc., which is, of course, going to slow their metabolism. Okay, the kind of representative local anesthetic is cocaine. You guys discussed cocaine and its mechanism of action in terms of like monoamines, right? And catecholamine release, dopamine release, etc. It also has this action as a local anesthetic, which is different from that. Okay, so cocaine was the first local anesthetic that was used. First found in leaves of the cocoa shrub, and it's an ester of benzoic acid and how do you pronounce that? Methylcognine? Methylectine? I don't know. Anyway, leave that to medchem. Okay, and this did used to be used a lot as a local anesthetic, but it's cocaine's obviously a drug of abuse, so use is on the decline. This slide shows the cocaine mechanism of action. Basically the same slide that I had drawn out earlier in the lecture. So we have cocaine here. Okay, so this is the membrane, right? And here's our sodium channels, voltage-gated sodium channels. Cocaine and other local anesthetics, to work, they've got to pass through the membrane. Okay, they pass through the membrane. They get ionized in the membrane, and once they get ionized in the membrane, then they're going to get up and block these voltage-gated sodium channels. So if you inject, if you put cocaine on an area where for some reason the nerves aren't working, right, or not firing much, the local anesthesia is going to take longer to occur because those channels need to be open for the local anesthetic to get back up and block them. Okay, I don't think we don't have too much time. This slide just goes through some local anesthetics. I think you guys can look at it on your own. And I'll ask pretty general questions about local anesthetic mechanism of action, that sort of thing. I'm really concerned that you know mechanism of action, a little bit about their potential toxicity and the co-use of vasoconstrictors with them. Right, the main thing. This slide is one you can look at. It's kind of hard to see here. You want to blow it up on your computer, but it just shows lidocaine mechanism of action. In terms of clinical uses, which most of the rest of this presentation goes over, I'm going to go ahead and let you guys just read the rest of this lecture on your own, okay? They get, these things get injected in different ways, different areas, but because of the abbreviated lecture in part, I'm going to test, on basically the pharmacology and not the clinical stuff. But you should go ahead and look through this. Okay, so there is that. For the exam, I am going to. Oh, I hope I don't regret it. You don't regret it. Use ExamSoft, which means I guess you have to bring the computer. Mm-hmm. What do you guys like, ExamSoft or hate it? Hate it. You want me to not use ExamSoft? Yeah. Yes. Like paper and ABC?
While you still have the option.
Scantron? Yeah. Want me to use Scantron?
Yes,
I'll try. Okay, it'll either be paper and pencil or paper and pen or Scantron then.
Yay!
Scantron. Okay. All our. I mean, I heard a pretty strong reaction, so I'm going to go with your strong reaction. Well, one thing it might mean is it might take us a little longer to grade the exam. That's fine. That's okay. So, well, that makes things easy. Okay, so I'll do that again. I tried to ask questions about classes of drugs and how classes of drugs work. If I bring up, if a drug there's a slide that has that drug as the title and then goes through that drug, or if the drug's a prototype, I might not tell you, with the general class it is, but otherwise, if I pulled out a drug you might not see a whole lot, a more obscure drug, and ask a question in order to ask questions about alpha-1 agonists, I'll tell you what that drug is. So I'm trying not to, try to focus on classes of drugs so you know that.
Is it all multiple choice?
Yeah. Oh, well, now I might have a fill in the blank or two.
Oh, I hate this. No. Back to Scantron. Back to
Exam's off the sign.
You guys are tough customers, man. I try and be very, you guys saw my questions before. I try to be pretty straightforward with my questions. So it'll mostly be multiple choice. What there will be, I can pretty much guarantee it is, I'm going to pull, okay, first of all, you don't need to know the histamine one yet, right? But these things, right, these worksheets, there's going to be parts of the worksheet on there, on that exam, and I'm going to ask you to fill in a couple of boxes, okay? That's why I want you guys to go through these and do these. And so we have all these here to practice with. Okay, so that'll be on there for sure. Just I want to test that you've done this stuff and understand the basics about sympathetic, parasympathetic nervous system, the main receptors that are there, the main transmitters that get used. Because again, it's super important, and it's going to come back for pharmacology later. And actually, again, this is stuff that should have been really covered at the beginning of the year. So it's the really basic stuff. So it's important. So there will be something like that. So you want to be able to fill these things out. And as you'll see, some of these tissues will express different levels of, for instance, muscarinic receptors or what have you. So, and the answer sheets I've given you, those guys show the main ones, right? The main receptors, because you get some tissue where there'll be 4 times as much M3, muscarinic 3 receptors expressed versus muscarinic 2, which of course are going to have different effects, but the overriding effect would be M3 activation. So that's what I've used in the answer sheets. Okay, but I think you want to take these and feel free to just quiz yourself. I was going to use these and go over these in class, right? But obviously, because of the snow days, those were the days I was going to do this, so we missed those. If you have questions, feel free to ask. Feel free to email me too. But there we go. Good luck, and I'll see you Friday.